I've been asked to talk to you today on behalf of Sussex MSK Partnership East about hip and knee osteoarthritis. There are many common misconceptions that sometimes are unhelpful in allowing people to manage their condition of osteoarthritis. Today, I'm hoping to dispel some of these myths and explain more about osteoarthritis as a condition and its management and some of the science behind it. So I want to start by giving you a definition of osteoarthritis. This definition comes from the National Institute for Health and Care Excellence, who provide advice for the NHS. You'll note that it defines osteoarthritis in terms of pain, functional limitation, and quality of life, not structural change. It's recognised that osteoarthritis can impact significantly not only on people's physical ability, but also on their mood, their self-image, their confidence, and social interactions. So what you will see from the diagram here is some of the structural changes that occur with osteoarthritis. It's often poorly described as wear and tear, and that's not the full picture that I want to talk to you about today. On the left of the diagram, you will see a normal joint where the ends of the bone are covered in cartilage, and that looks like a nice healthy joint. On the right-hand side, you will start to see some changes on the images. We do see wear, and often we see a reduction in the cartilage at this point. However, it's important to note that this is accompanied by an active remodeling process of the bone itself. And sometimes you get thickening of the soft tissues, which accounts for some of the changes that you see on that diagram. Osteoarthritis is not an inevitable age-related process of the body wearing out, but an active process of joint remodeling. So, my next slightly unusual presentation talks about door hinges. Now, you might ask what relevance this has. Well, the significance of this is that we can look at these hinges, and some of them look newer, some of them look older. And we can make an assumption about how well that hinge is functioning. It's quite similar in the form of investigations such as X-rays and MRIs, in that they will often show us structural change in the joint, but it doesn't show us how well it's working or even whether it's painful for an individual. So going back to the NICE guideline development definition, it specifies that clinical findings alone are sufficient to make a diagnosis of osteoarthritis in individuals, and that actually additional imaging procedures can increase the cost, but increase the cost without any significant benefit, which is the important thing to take away from that expression. So investigations are sometimes required, and of course we do use them, and that's often to exclude other diagnosis or for planning surgery in the later stages. X-rays, MRIs, blood tests are all possible investigations that someone may go through. So people often say to us, they often say, don't I need an X-ray? Is it not important to see what's on the X-ray? And we say, well, not always, because we see people where they have very mild structural change but are reporting high amounts of pain. And then at other times, we see people who have got significant structural change and very little pain. So in the general population of patients, or generally over the age of 50, you will see that about 25% of adults have osteoarthritis on imaging, but only 13% of those in the knees will be symptomatic. Likewise in the hips, 11% will show evidence on the X-ray, but again, only 5% be symptomatic. So it's round about half of them will actually have symptoms compared to the structural change that is seen. So people will often ask, what will be my progression of symptoms over the years? Well, this is very variable, and the outcome is variable as well. Improvements in structural change are rarely seen once it's established on X-ray. However, improvements in pain and disability over time are common. And what we do know that is 1 in 3 will roughly stay the same, 1 in 3 will improve, and 1 in 3 may get worse. Little is known about the risk factors that lead to the progression of osteoarthritis, and they may be different from what initiates the process in the first place. Having said that, being overweight and obesity is thought to make an important contribution at all stages. So the next myth I want to talk to you about today is pain equaling harm, and you will see a big red cross through that to say that that is not true. So why is this? To understand this, it may be helpful to explore the concept of pain a little further. Pain is often misconceived as being a physical thing within our tissues itself. And in truth, it's our brain's interpretation of the information received based on what it perceives the threat to be. So similar to a burglar alarm system in the top left-hand corner, it's there to protect you by acting as a warning system. However, the sensitivity of this warning system can be attenuated by many factors, including previous experiences and our emotions. So the amount of pain you experience does not necessarily relate to the amount of tissue damage that may be present. So we can all think of examples of this. So soldiers at war who have quite severe injuries and report very little pain, or when we get a paper cut, where there's barely any tissue damage, but significant amounts of pain are often felt, muscle cramp being another one that's similar to that. Our environment can also influence the experience of pain as well. So people will often report that pain is worse at night. So again, like our clock, if you've got a ticking clock at night, you become more conscious of it because we're not distracted from it. Memory can also play a role in this. So I'm sure we can all think of a certain smell or a memory evoking that memory of a certain person in our life at some point. It's in a similar way that situations or environments that have previously been threatening or painful can trigger a pain response through our memory. So, exercise causes osteoarthritis? Well, what we found about this is it isn't true. Exercise at a recreational level shows no increase evidence of osteoarthritis, and in fact is probably likely to reduce the risk. Research involving recreational runners has shown that there is a lower incidence of knee osteoarthritis in these individuals. So then we do think about, well, what does cause osteoarthritis then? Well, it's important to know that osteoarthritis is not a disease or a single condition, but a common complex disorder with multiple risk factors. And relevance of these risk factors varies between individuals. On the left-hand side of the slide, you will see systemic factors. Now, these relate to you as an individual, and on the right-hand side, you will see the mechanical factors relating to the loads applied to our joint. And in the middle, we have to consider other factors that influence the pain that we experience, remembering back to our slide that pain does not always equal harm. You may note that obesity is listed both as a mechanical and a systemic factor, and I'll explain more about that. So excess body weight is a risk factor, both for the development and the progression of osteoarthritis. So for every pound of weight that you gain, your knees will carry an extra 4 and your hips an extra 6. In addition to this increased load, obesity promotes inflammation throughout the whole body. This can then lead to an increase in metabolic conditions such as diabetes, high cholesterol, and osteoarthritis, hence its inclusion in both the categories. There was a study taken part in America a while ago that looked at 6,000 individuals over the age of 60 and found that the number of people with knee pain went up from 15% in people who weren't overweight to 56% in those in what were considered to be the severely obese category. To simplify this, if there were 20 people in a room, 3 people with a normal weight would have knee pain versus 11 people in the group of obese people. The incidence of osteoarthritis does increase with age. However, as previously discussed, it's not an inevitable consequence of age. Genetics have also been found to have a significant factor in hip and knee osteoarthritis, and that is certainly something that we are unable to influence. Mechanical risk factors also will contribute, and again, some of those we can't influence, such as our alignment, but other things such as muscle strength, we can do something about. So, is exercise harmful? Well, this view is primarily founded on the belief that it's a process of wear and tear. And we spoke earlier about it being an active remodeling process. So in actual fact, exercise is proven to improve pain and function. There was one study, in fact, that found that taking part in a 12-week program of exercising for 1 hour twice a week reduced the uptake of hip surgery by 44%. And they also reported that they felt more flexible and physically able at the end of the study. So what are the health benefits of physical activity? Well, this is an infographic that was produced by our government and encourage us to exercise by telling us what the potential benefits are. We now understand there's a variety of these benefits related to exercise, including improvements in sleep and quality of life, the management of stress and depression, and also maintaining that healthy weight, which we've discussed is important. There's also other effects more significantly, like reducing conditions such as dementia, cancer, and type 2 diabetes. So how much physical activity should we be doing? Well, again, this is an infographic produced to provide us with some guidance on this. It's recommended that the average adult should be doing 150 minutes of moderate intensity exercise of an aerobic nature. Now, aerobic means it's something that will raise your heart rate, such as brisk walking. Now, if you struggle with walking, there are alternatives to this, such as cycling or swimming, which again would be able to raise your heart rate. It also recommends that twice a week there is a strengthening element to your exercises, and that should involve some progressive loading. Now, that might be using weights or going to the gym, or it could be doing something like yoga. It's about suiting it to the person. Having said that, if you're not able to achieve the 150 minutes, any amount of exercise will be of benefit to you. And what you will find is that by gently starting with a small amount, you should be able to build up your tolerance of exercise to be able to do more over time. Equally, the harder you work with an exercise, the less minutes are recommended. So if you were doing more what would be considered higher intensity exercise, it's more like 75 minutes a week where you will see the health benefits. Now, the sharp-eyed among you may note that it says 19 to 64-year-olds. It is the same for the over 64-year-old population in the recommendations. It's just the government hadn't produced a pretty infographic that I could put up on a slide for you. Scientists are still exploring the reason why exercise helps with osteoarthritis. One of their findings, they think, is by a process called mechanotransduction. Now, this is a very complicated looking slide, and we're certainly not going to go behind the science of what this is today. What we do believe is that increasing our understanding is that cell signaling may be able to treat osteoarthritis in the future through manipulating this process. So, in essence, what we have found is that cells talk to each other in response to mechanical triggers, and this can lead to changes in the tissues overall. What we do understand is that immobilizing joints, like our poor people in the picture here, will lead to a loss of bone and cartilage. However, fortunately, these effects can be reversed with exercise and getting moving again. So exercise can be viewed as a form of load that can be used to promote helpful tissue adaptation. Further to this benefit of load, we've found that this can be enhanced by variety in the type of exercise that you do. In other words, different types of load, different rates of doing the exercise, and directions as well. So to put it simply, doing the same exercise day in, day out will not have the same benefits, and variety is best. So one thing that we often hear is taking painkillers will allow me to harm myself. Well, this is somewhat of a misrepresentation in the fact that it's implying that we can kill the pain that you're experiencing and take it away completely. What would be better phrase of using is a pain softener. So, in other words, we're not trying to take it away, we're trying to take it down to a manageable level that would allow you to move more comfortably. There's a wide variety of these so-called now pain softeners available, through from paracetamol that you can buy over the counter, to non-steroidal anti-inflammatory gels, through to strong opiate-based medicines. Now, obviously, depending on the strength of the medication, there are risks and benefits for taking these, and it's important to have a discussion with either your GP or your pharmacist to get advice about this on an individual basis for yourselves. The next slide is a pyramid which is meant to represent the spectrum of treatment available for osteoarthritis. And the width of the band represents how many people should receive each of the treatments. So locally, approximately 18% of the population have a diagnosis of osteoarthritis. So in Eastbourne alone, that would amount to nearly 9,000 people. Equivalent figures for the hip sit at around 11%, and that's nearly 5,500 in Eastbourne. Everyone with a diagnosis of osteoarthritis should receive the core management as seen at the bottom. This includes exercise and education. And when we talk about education, it's allowing you to understand the condition and then to make some choices about what your management options are. And where appropriate, it includes weight management. Only a small percentage of people will reach the top of the pyramid where surgical intervention is indicated. And we can't predict that course of progression of an individual over the time, or even if someone will eventually need that as an option. Additional measures that lie in between this may be escalating levels of pain softeners, as we discussed before, or other adjuncts such as using a stick, TENS machines, manipulation of the joints. So, from the talk today on osteoarthritis, if you were to take two things away from you, I would like you to take away the benefits of staying active and being a healthy weight. So some of you may have heard of the Escape Pain Programme. It's a national programme that has been set up for knee and hip osteoarthritis and is something that is run locally by our physiotherapy departments in East Sussex. Escape enables people to self-manage and cope better with arthritic pain through education and exercise. Several agencies endorse the Escape programme and have partnered up with it, including ones that you might have heard of, such as Versus Arthritis, NHS England, Sport England, and the National Lottery. The reason they endorse this programme is that there has been a lot of research done into it, and therefore they've managed to demonstrate the benefits that patients get from taking part in this programme. They also continue to take data all the time, so anyone who goes through this programme will fill out questionnaires about their health and their physical ability at that moment in time, and that is used to be sent back to Escape so that they can capture all this data and continue to show these benefits. Health benefits that are reported include having less pain, an improved physical and mental well-being, increase in self-confidence, less reliance on medication, and hopefully a reduced need for surgery. The programme is designed for the over 45-year-old population, and it's run over a 6-week period with twice-weekly sessions equaling 12 sessions in total. The hour-long part of the course has 20 minutes where the group will go through a discussion topic that is relevant to osteoarthritis. So this might be pacing your activity or greater detail on using painkillers. And then the other 40 minutes of it will go through some more specific exercises which are meant to be progressive in nature over the 6 weeks that the programme will run. I've had patients in recently who have been singing the praises of the programme and telling me how they've kept in contact with each other and meet up and go to the gym and will socialise afterwards, which is nice to hear. And you will, depending on whether you can read it from here, I'm going to read out some of the testimonials have been, I have benefited 100% from the class, my right knee is much improved, and I have a training programme to help me for the rest of my life. Another patient feedback was, it's given me the confidence to exercise more than I thought possible at my age and due to the fact that I have osteoarthritis. Now, not everyone may be able to access that programme. It may be that the group doesn't suit you or the timings of it doesn't suit you. There is the option of an online video for this, which you can do on a desktop or on a smartphone app, where you can get the same learning modules and go through the exercises. The only downside of that, if you wanted to call it a downside, would not be having the social interaction of being able to discuss it with a group, because generally people start together in a group and end together in a group and go through that 6-week journey together. When it comes to exercise, you must remember that it should feel challenging and it's okay for it to be painful at times. If that pain is at an unacceptable level for you, then rather than trying to stop the exercise completely, try to reduce the amount that you do of them rather than giving up on it at that stage. The other thing that you need to note from exercise is that the number of repetitions and sets you do of an exercise is very variable from one individual to another. But the aim of doing an exercise is that your muscle should start to feel tired by the end of it. So as a rough guide, an aim of doing 3 sets of 10 can often be a useful benchmark, and some people will be less than that, some people more. However, if you're managing to do 20, 25 repetitions of an exercise, we'd be questioning whether it was too easy for you and whether some other adaptation needs to be made to that exercise to make it harder for you as an individual.